So what about, Dan, new drugs for people who actually might have resistant virus? It's uncommon, but still real person. What
I think it's important to acknowledge that even though for the vast majority of patients, the drugs we usually use work really incredibly well, there are still a small number of patients who have extensively resistant HIV where coming up with a fully suppressive regimen can be a challenge. And fortunately, there are two new drugs that are in development. Both of them are entry inhibitors. So one of them is actually an antibody that has to be given by injection, and that is ipilimumab. That's a drug that actually, oddly enough, binds to CD4. And it doesn't stop the virus from binding CD4, but stops the virus from getting in afterwards. And it's at least in the laboratory, doesn't seem to mess up the function of CD4 cells. And there have been clinical trials that show that the drug has a significant effect on virus load, so it's highly active, and it is very well tolerated. And when combined then with other active drugs, can improve the chances of virologic suppression in a patient with highly resistant virus. The other drug, which is also an entry inhibitor, doesn't bind to a cell protein, but binds to the virus envelope, and that's a drug called fostemsavir. And that drug is also now in sort of salvage therapy trials where it's being combined with other active agents, and similar to ipilimumab, has been shown to be both highly active and well tolerated, and when given in the right combination, can lead to sustained virologic suppression. And it's called an attachment inhibitor in terms of the way it works. It may not be as active against all viruses because there's so much variation in envelope, but at least for the viruses we see most commonly here in the United States, it seems to be pretty active against the vast majority of them.
But they're not likely to move earlier in therapy, I guess, Eric, to second line or first line.
It's hard to imagine. I guess as we start to think about long-acting therapies, they'd have to change ipilimumab so they could be given even less frequently than it currently is.
It's once every 2 weeks, is how it's being studied.
So in order to think about it in that context, you'd have to do better than every 2 weeks.
Sure.
Especially like you say, it's an infusion. It's not an intramuscular injection. So I don't think so. And fostemsavir, I think, is twice a day. So again, it's going to be really important for select people who need it. And it is remarkable. And the phase 3 development of these drugs is interesting because it's so different than the new drugs for resistance patients we've seen in the past, because the population is so small, which is great. And they basically usually just give it for a week, show how intrinsically potent it is, and then add it to an optimized background regimen.
Monitor for safety.
Yeah, and they get, about 50% of people get to undetectable levels, which is amazing in the current era.
There's a third entry inhibitor, which is also an antibody, Pro-140, that blocks the CCR5. Other receptor for HIV, CCR5, and that can be given by injection subcutaneously. So although it has to be given weekly, patients can self-administer it, and it's also being studied in potential salvage situations. The trick there, though, is that the virus can change the receptor that it uses, and many patients who have advanced disease or who have had a long history of treatment and many rounds of virologic failure, the virus will have changed to the form of virus that can't be inhibited by Pro-140. So we'll have to see what the clinical trials show.